Hello, everybody. My name is Shanaz Sultan, and I'm an associate professor in the Division of Gastroenterology, Hepatology, and Nutrition at the University of Minnesota. I'm going to be talking to you about the management of constipation. I have no financial disclosures related to this presentation, and at the end of this talk, you should be able to discuss the prevalence and pathophysiology of constipation in CF patients and discuss the role of common and newer pharmacologic agents to treat constipation. Estimates of constipation in the CF population range from 10 to 40%, and it's one of the top 3 symptoms that CF patients complain about to healthcare providers. The pathophysiology of constipation in CF patients is multifactorial. It's due to decreased intestinal fluid and a dehydrated luminal environment, bicarbonate deficiency, which leads to an increase in acid content, as well as factors like mucus accumulation, dysbiosis, inflammation, and dysmotility. How do we define constipation in cystic fibrosis patients? The European Society for Pediatric Gastroenterology, Hepatology, and Nutrition has developed the following working group definition for constipation. Number 1, abdominal pain and or distension. Number 2A, reduced frequency of bowel movements in the last few weeks or months. Number 2B, increased consistency of stools in the last few weeks or months. Number 3, symptoms 1 and 2 are relieved by the use of constipation. And to have constipation, you need to have number 1 or number 2A or number 2B and number 3. The difficulty in using this definition is that it's hard to distinguish between abdominal pain versus bloating, and it's hard to operationalize reduced frequency and increased consistency. In the non-cystic fibrosis patients, the common criteria that are used to diagnose functional constipation are actually the Rome 4 criteria. And I'll go over those with you now. So the Rome 4 criteria say that in order to be diagnosed with constipation, you need to have at least 2 or more of the following symptoms: straining, lumpy or hard stools, which are defined as a 1 or 2 on the Bristol Stool Form Scale. We'll talk a little bit about the Bristol Stool Form Scale in the next slide. A sensation of incomplete evacuation, a sensation of anorectal obstruction or blockage, the use of manual maneuvers to facilitate defecation, and all of these should be present for at least greater than 25% of defecations, and less than 3 spontaneous bowel movements per week is also a criteria. It's also important to know that these criteria should be present for the long term. So you should have at least symptoms for 3 months with a symptom onset of greater than or equal to 6 months before diagnosis. So this is the Bristol Stool Form Scale, and this is a really helpful tool to use when talking to patients about constipation. Because stool form correlates with intestinal transit time, the shape and the consistency of the stool can be used to help describe the degree or severity of constipation that patients have. And this actually can be useful to monitor response to treatment and can be used to kind of assess where they are at baseline. In talking to patients about constipation, it's important to review their fluid intake, dietary fiber intake, as well as the amount of exercise they are having, as these are all modifiable factors that you can also that you can use to actually improve constipation symptoms before moving on to oral agents. It's also important to review their medications to see if there are any culprits that can contribute to constipation symptoms that could potentially be modified. And also important to review if they have any red flag symptoms such as weight loss or rectal bleeding, because we know that cystic fibrosis patients have a higher risk of developing colorectal cancer at an earlier age. So it's important to talk about these symptoms, and if these symptoms are present, to pursue an endoscopic workup. Important to also tease out whether there's any suggestion of intermittent mechanical obstruction contributing to symptoms from intussusception or rectal prolapse, and to review if there are any endocrine or metabolic abnormalities that may be exacerbating symptoms of constipation. So let's move on to the treatments for chronic constipation. The first line treatments include fiber and laxatives, and second line treatments include some of the pharmaceutical agents such as secretagogues. These include chloride channel activators or guanylate cyclase C activators, as well as prokinetic agents such as 5-HT4 agonists. So what is the evidence for the use of these drugs in CF patients? Actually, there's only one pilot study of lubiprostone in adult CF patients that included 7 patients who were treated with lubiprostone for 4 weeks. And in these 7 patients, the authors noted an overall improvement in constipation symptoms, but no improvement in spontaneous bowel movements or change in Bristol stool scale. So the evidence to support the use of these medications in CF patients actually comes from indirect evidence in the CIC population or the IBS-C population. Let's start off by talking about fiber. It's important to actually recommend the use of soluble fiber as it's better tolerated and more effective than insoluble fiber. The 2 agents for which we have the most evidence to support their use are psyllium and isphagula fiber. The total amount of fiber in order for it to be effective should be in the range of 25 to 30 grams per day, and that includes oral or dietary fiber. And then it's important to increase the dose gradually to minimize side effects such as flatulence, bloating, or nausea. These are the first-line agents that we use to treat patients with cystic fibrosis and include osmotic laxatives as well as stimulant laxatives. Osmotic laxatives like polyethylene glycol, lactulose, or magnesium citrate work by drawing water into the intestine to hydrate and soften the stool and thereby increasing transit time. Stimulant laxatives such as bisacodyl, sodium picosulfate, or senna actually work by irritating the sensory nerve endings to stimulate colon motility, and they reduce colon water absorption, which also then leads to increased transit time. A third agent that's commonly used is actually not really a laxative, but a surfactant stool softener called docusate. And this agent's mechanism of action is to allow water and lipids to penetrate the stool to hydrate and soften fecal material. But it's not a very effective medication for the use for the treatment of constipation. So this is a meta-analysis that shows the pooled effect estimate of osmotic laxative and stimulant laxatives across about 8 randomized controlled trials, including anywhere from 800 to 1,300 patients in total. And you can see across these agents, laxatives are extremely effective in improving constipation symptoms with a pooled effect estimate of 0.52 ranging from 0.46 to 0.60. One of the most important first-line agents used to treat constipation. Let's talk about some of the newer agents like our chloride channel activators. And the main medication that is in this class is Lubiprostone. Lubiprostone is non-absorbed. It selectively activates type 2 chloride channels, stimulating the secretion of chloride-rich intestinal fluid. This drug has mostly been studied in patients with CIC and IBS-C, and the side effects include diarrhea and nausea. It's available in 2 doses, 8 micrograms twice a day and 24 micrograms twice a day, and we usually recommend taking it with meals. These are the studies that have supported the use of lubiprostone for chronic idiopathic constipation. So in these studies, the primary outcome was the frequency of spontaneous bowel movements, meaning a bowel movement that did not require a laxative. And you can see that individuals that received lubiprostone had an increase in their frequency of weekly spontaneous bowel movements as compared to placebo, with an increase of at least 1 to 2 spontaneous bowel movements per week. Moving on to our guanylate cyclase C receptor agonists. The first drug I'll talk about is linaclotide, and linaclotide works by stimulating the secretion of chloride-rich intestinal fluid through the CFTR receptor. And it has been studied in patients with chronic idiopathic constipation and IBS-C, and side effects include diarrhea and abdominal pain. It's available in 2 doses, 72 micrograms a day and 145 micrograms a day. And in 2 randomized controlled trials evaluating the use of linaclotide in patients with CIC, we actually know that linaclotide is pretty effective. If you look at the primary outcome in these studies, the outcome was called a primary responder endpoint at 12 weeks, and this is actually one of the most rigorous endpoints that's been used in many of the CIC trials. And it includes greater than or equal to 3 complete spontaneous bowel movements per week, and an increase of greater than or equal to 1 complete spontaneous bowel movement per week for at least 9 out of 12 weeks. In order to be counted as a primary responder, you needed to have fulfilled this criteria. And if you look between the patients that were treated with linaclotide versus placebo, the response rate in terms of individuals that met this endpoint was in the range of 16 to 20% in individuals treated with linaclotide versus only 3 to 6% in individuals who were in the placebo arm. Our second guanylate cyclase C receptor agonist is plecanatide. And again, it works via a similar mechanism by stimulating the secretion of chloride-rich intestinal fluid. Also studied in patients with CIC and IBS-C, and similar side effects. Here, the dosage is actually once a day dosing for 3 milligrams. And here's the data for plecanatide. So here, the primary outcome was actually proportion of durable CSBM responders. And this was defined as a weekly responder for at least 9 of 12 treatment weeks for at least 3 of the last 4 weeks. And a weekly responder meant that you had an improvement of at least greater than or equal to 3 complete spontaneous bowel movements per week, and greater than 1 complete spontaneous bowel movement from baseline. And you see here that individuals that were treated with plecanatide, about 20 to 21% of individuals were responders, whereas only 10 to 12% of individuals in the placebo arm were considered responders. So let's talk about our last class of medications. These are the serotonin 5-HT4 receptor agonists. And the drug that we have in this class is prucalopride. And prucalopride works by improving colonic motility and decreasing transit time. And prucalopride is actually a selective 5-HT4 receptor agonist. So it actually has not been shown to be associated with any cardiovascular adverse effects, unlike some of the other agents that are in the 5-HT4 or that work on serotonergic agents, where there has been a signal and a concern for cardiovascular adverse effects. This has been mostly studied in Europe in patients with CIC and IBS-C, and across 6 trials that included about 600 patients. About 26 to 30% of patients actually had improvement in their constipation. This was measured as a mean frequency of greater than or equal to 3 complete spontaneous bowel movements per week over 12 weeks, as opposed to the placebo group, in which we saw only about 12 to 16% of patients meet this primary endpoint. The side effects include diarrhea and headache, and it's available in a 2 milligram per day dosing, but it's recommended that you use 1 milligrams in patients with any renal disease. So of all the slides in my talk, this is probably the most helpful, because it lays out the medications that we use as second-line treatments for CF patients. Includes the 3 secretory agents we talked about, lubiprostone, linaclotide, plecanatide, as well as the prokinetic agent prucalopride. And it lays out the dosages as well as adverse effects. And you'll see that the adverse effects are pretty similar across these agents, mostly nausea, diarrhea, abdominal pain, flatulence, but they're dose-dependent reactions. So often by decreasing the dose or using every other day dosing, you can usually minimize some of these side effects. So what's new on the horizon? In the last few months, Tegaserod has actually gained reapproval. So Tegaserod is in the class of 5-HT4 receptor agonists, and it had been taken off the market by the company because of this signal for possible increased cardiovascular risk. And the FDA recently reviewed all the data for Tegaserod and reapproved it, but for a select group of individuals. So it's only approved for women with IBS-C who are less than 65 with no cardiovascular risk. The newest agent on the block is actually a very exciting drug called tenapanor, and this is a first-in-class small molecule inhibitor of the sodium hydrogen exchanger isoform 3 channel. And inhibition reduces absorption of dietary sodium and phosphate. It's actually also being used to treat hyperphosphatemia in renal failure patients, and it actually doesn't work through the CFTR channel, so it's a different mechanism of action. It has been approved for IBS-C patients, but it's not yet available on the market. And this is my last slide. I'll end with talking about the evidence gap that we really have for the management of constipation in CF patients. We really need more randomized controlled trials. to look at the effectiveness of these agents in CF patients. We need a better understanding of what are the relevant patient-important outcomes. Should we be using the same measures such as at least 3 greater than or equal to 3 complete spontaneous bowel movements per week and greater than or equal to 1 complete spontaneous bowel movement per week from baseline, or as well as a spontaneous bowel movement response? Should we be also looking at things like constipation severity as global measures, knowing that individuals also have a lot of global GI symptoms that are problematic or bothersome? And then also we need to use more standardized validated scales to look at outcomes in these patients, such as PAGI-SIM, PAC-SIM, and PAC-QOL. And this is the end of my talk. Thank you very much.
Today I'll be talking about the use of acid suppression in cystic fibrosis. I have no disclosures. So today I'll be discussing why we use acid suppression in cystic fibrosis, specifically focusing on the medications such as proton pump inhibitors that we use. And indications include peptic disease treatments, such as for NSAID ulcers or peptic ulcer disease, gastroesophageal reflux disease, and H. pylori, how acid suppression can improve the GI tract pH and optimize pancreatic enzyme replacement therapy, but also potential adverse effects and dangers of PPI. The definition of gastroesophageal reflux disease is quite vague. Based on the Montreal classification, it is defined as reflux which causes troublesome symptoms or complications. Disease usually indicates that they have symptoms at least 2 or 3 times a week. Classic symptoms include heartburn, regurgitation, dysphagia, or even chest pain. The incidence of gastroesophageal reflux disease and cystic fibrosis is quite common, with a prevalence of up to 30 to 80%. You can see in this, this picture from the CF Foundation Annual Registry from 2018 that almost over 20% of patients and up to 40% of patients have been diagnosed with gastroesophageal reflux disease based on the registry. And if you look at the incidence of GERD or peptic ulcer disease in cystic fibrosis, what you can see here again from the registry is that if you look at all comers, about 36% are identified as having gastroesophageal reflux disease. And this is significantly higher than other GI complications such as distal intestinal obstructive syndrome, pancreatitis, or even peptic ulcer disease. And if you compare it to other things you think about, including mental health issues such as anxiety or depression, it's much more, and similar to the prevalence or incidence of sinus disease in cystic fibrosis. What are the consequences of GERD and cystic fibrosis? Well, aspiration events due to proximal reflux, which can lead to lung decline and chronic rejection. There's also been studies looking at patients with cystic fibrosis, and there's been an increased incidence of Barrett's esophagus and GE junction adenocarcinoma, which are thought to be acid reflux mediated disease processes, with a 3-fold increased odds of Barrett's or related neoplasia in patients with cystic fibrosis with a younger age of onset compared to populations without cystic fibrosis. What is the pathophysiology of GERD and cystic fibrosis? Impaired acid neutralization by saliva and bicarbonate. You can have impaired esophageal motility, increasing your risk for acid reflux. You cannot clear things through the esophagus. The lower esophageal sphincter with low pressure or inappropriate relaxation is thought to be a major mediator of GERD and cystic fibrosis. Hiatal hernia, which is very common in non-cystic fibrosis populations, actually has a low prevalence in cystic fibrosis. Delayed gastric emptying can play a role in the pathophysiology of GERD and cystic fibrosis, as food and liquids can sit in the stomach and have a higher chance of refluxing. Altered thoraco-abdominal pressure gradients with greater inspiratory negative pressure seems to also be a major player in the pathophysiology of gastroesophageal reflux disease and cystic fibrosis. Transient LES relaxation is illustrated here, and you can see this is the upper esophageal sphincter, the LES, and esophageal motility studies, and you can see this relaxation here with proximal reflux. And 90% of reflux episodes in the adult patients with CF occur during transient LES relaxation. How do we diagnose gastroesophageal reflux disease in any patient? Well, classic symptoms such as heartburn, regurgitation, exacerbation by meals, worse when laying down, or nocturnal symptoms, and relief with therapy such as acid suppressive medications. You don't need anything else However, atypical symptoms such as chronic cough or worsening lung function, they may require 24-hour ambulatory pH studies or upper endoscopy or even motility studies to look for complications and to assess for other potential differential diagnoses. This slide tells us about the physiology of gastric secretion as well as how our medications to suppress acid work. Remember, the parietal cell actually pumps out hydrogen, which is the major way to produce acid. And there are acid neutralizers, magnesium hydroxide, aluminum hydroxide, calcium carbonate. There are cytoprotective agents which work on the mucus layer to protect our stomachs from acid. And then there's those medications that reduce acid production. And this is what the focus of my talk is. Specifically H2 receptor blockers and proton pump inhibitors. Anticholinergic agents block through the acetylcholine receptors, but they have a lot of side effects and are not used. You can see that proton pump inhibitors irreversibly block the hydrogen pump. So they're actually the best drug at reducing acid suppression, and it makes sense that they are used very commonly in cystic fibrosis as well as the non-cystic fibrosis patient population. H2 receptor blockers can block the histamine receptors in a number of ways, but reversibly, so not as good at blocking acid. And that explains why PPIs and H2 receptor blockers are used quite frequently in cystic fibrosis. So this slide, again from the registry, shows that the PPIs increase exponentially up to age 20, and about 50% of patients over the age of 20 have documented PPI use. A smaller number, up to 20%, with H2 receptor blockers, and you can see the proportion of all individuals who are endorsed as being on a PPI or H2 receptor blocker. And you can see that there's been an exponential rise of the use of PPIs in the CF registry over time. This only goes to 2010, but our personal data shows that our patient population, about 70 to 80% of our adult patients with CF are on endorse a PPI or an H2 receptor blocker. And what is the indication for PPI use in patients with CF? Well, based on this retrospective study, actually in pediatric population, a third endorsed PPI use for gastroesophageal reflux disease. Approximately 20% endorsed it for enzyme replacement, and the largest number indicated it was for both, 35%. And interestingly, 16% had no clear indication for PPI use. And you can see the dosages and the frequency vary with a duration of already 5 years in this pediatric population. Well, if patients are using it not only for GERD, what's the incidence of pancreatic enzyme replacement therapy in cystic fibrosis? Well, you can see here a lot of our patients with CF are endorsing pancreatic enzyme replacement therapy, over 80% up to age 40. It's interesting that 64% of infants are tested, and even those not tested, 87% are prescribed pancreatic enzyme replacement therapy. 24% with normal elastase, indicating no pancreatic insufficiency, are still prescribed pancreatic enzyme replacement therapy. And why would you even consider using acid suppression for pancreatic enzyme replacement therapy? Because in the cystic fibrosis population, as highlighted by this orange color versus controls, you can see the small bowel pH is lower, and this is the proximal duodenum is the zone of most fat absorption. And pancreatic enzymes are not efficient if the pH is too low. And so cystic fibrosis patients may start with a lower small bowel pH, therefore making the pancreatic enzymes less efficient. And the effects of low duodenal pH in our patients with cystic fibrosis lead to potential poor release of enteric-coated pancreatic enzymes, decreased lipolytic activity of lipase and bile acid precipitation. Variable results have been shown with H2 receptor blockers, and this may be because H2 receptor blockers are not as good as PPIs at blocking acid. PPIs have demonstrated improved fat maldigestion in anthropometric variables, and I'll show you this data in a few slides. And then the interruption of PPIs have led to nutritional deterioration. Double-blind placebo-controlled studies have shown that use of a PPI as adjuvant therapy with pancreatic enzyme therapy results in less fecal fat malabsorption. And this is one of those small randomized controlled studies. This one was in adults, and it looked at patients who had fat malabsorption as measured by fecal fat excretion. And they randomized them to 2 capsules of pancreas 3 times a day, 4 capsules 3 times a day, 2 capsules 3 times a day, plus omeprazole, low dose, or 4 capsules. And what you find is that the percent fecal fat excretion as a measurement of fecal malabsorption significantly decreases when you add more pancreatic enzymes and add the omeprazole. This is another study, prospective open label study, looking at before and after lansoprazole to pancreatic enzymes. And they looked at acid steatocrit, which is another measure of fecal malabsorption. And they found that the numbers decreased after the addition of lansoprazole to pancreatic enzymes. And this is where it shows anthropometric measures such as weight, length, and measurement of skin folds and muscles, all increased 3 months after. So weight before and weight 3 months after, length before, length after. And you can see all of the numbers overall improved. This is a study that actually shows the opposite findings. This is a study looking at all clinical trials by Abbott with pancreas. And what they found that they looked at more than just cystic fibrosis patients. They looked at chronic pancreatitis patients on pancreatic enzyme replacement and pancreatic surgery patients. And they looked at the coefficient of fat absorption, again, a marker of fat malabsorption. And they found no significant difference whether you were on a PPI in terms of the coefficient of fat absorption. This highlights placebo-controlled studies specifically, and again, no significant difference with acid suppression and pancreatic insufficiency. So based on these studies, the pancreatic enzyme replacement therapy guidelines are somewhat unclear, and whether an acid suppressive medication is necessary to aid in absorption. Some guidelines suggest that you could add an H2 receptor blocker or a PPI if pancreatic enzyme replacement therapy is maximized and malabsorption is still present. Some other ones suggest that acid suppression is not routinely required with pancreatic enzyme replacement therapy, but some patients may still benefit. So what do I recommend in terms of the use of PPI in pancreatic insufficiency? Based on the data, I would say that if persistent fecal fat malabsorption is present despite hypercaloric diets and maximized enteric-coated pancreatic enzyme dosing, you should consider acid suppression, because enteric-coated enzymes need to be exposed to a higher pH for enzyme release, and we know that CF patients may have a lower duodenal pH, and that there has been some data showing that acid suppression does improve acid steatocrit or markers of fat malabsorption, as well as anthropometric parameters. And although H2 receptor blockers may be used, they don't seem to be quite as good at acid suppression, and they have more variable results, whereas low-dose PPIs may be good enough to show a change. Well, why shouldn't everyone be on an PPI or acid suppressive medication? Well, because there are adverse events for any medication, including acid suppression. And this chart highlights a number of them. Obviously, in a 20-minute talk, I don't have time to address all of these. I'll address some of the more notorious potential adverse events, such as infections, kidney issues, and excuse me, vitamin and mineral deficiencies. So I'll talk about these potential adverse effects of PPI therapy, such as kidney disease, increased risk of infections, bacterial overgrowth, or C. diff, enteric infections, and pneumonia, the effect of acid suppression on absorption and metabolism of drugs, minerals and vitamin deficiencies, fractures. I really won't highlight dementia or coronary disease or stroke or cancer risk, because I think overall there's very little data, even more so than these potential adverse events. So this is that small retrospective study looking at the pediatric population and comparing PPI patients with control patients and looking at some of these adverse events like hypomagnesemia, hypocalcemia, low bone mineral density, positive C. diff toxin, or pulmonary exacerbations. And interesting enough, in this small study, it showed no significant difference other than more frequent pulmonary exacerbations in the PPI group versus control. Again, this is a retrospective study. Significant confounding may play a variable. What about kidney injury? Well, there are definitely a number of case reports that indicate acute interstitial nephritis has been described with PPI use. It's an idiosyncratic and all-class drug effect. Chronic kidney disease and stage renal disease, acute kidney failure, these are all as well described. Acute interstitial nephritis is usually within the first year and not dose dependent and can recur. Meta-analyses have looked at possible chronic kidney disease with hazard ratios that are pretty low, 1.1 to 1.5. There have also been meta-analysis of at least 7 studies looking at pooled relative risk, again, for acute kidney injury of 1.61. The problem with all these studies is that there's heterogeneity of the studies, and overall grade of evidence is low or insufficient quality. What about pneumonia? Well, the thought is that loss of bactericidal effect of gastric juice. And again, most of these studies are retrospective studies. seem that some of them indicate that more short-term data within 30 days of starting a PPI might have higher risk. But the meta-analysis did not show increased risk of respiratory infection, specifically pneumonia. The odds ratio is 1.42, and you can see here that it crosses the line, so it's not significant increased risk of respiratory infections. What about changes in gut microbiome, or SIBO, small intestinal bacterial overgrowth? Gastric acid is hospitable to bacterial and microorganisms. So if you remove gastric acid, then you might increase the number of specific bacterial microorganisms. We see increased number of streptococcus organisms, usually in the oral cavity. But again, this change in the microbiome is of unclear clinical significance. However, there are a number of meta-analyses that show a modest association of PPI use and small intestinal bacterial overgrowth. Again, similar odds ratios in the 1.71 range, but with some more clinical significance than some of the other data. Again, how they diagnose small intestinal bacterial overgrowth seems to be important, and that in itself is fraught with issues. What about other GI infections? The use of PPI may lead to increased enteric infections, but again, retrospective studies looking at increased Salmonella, Campylobacter. There's also been a number of meta-analyses looking at C. diff, positive association, whether it be C. diff toxin or C. diff associated disease, as defined by diarrhea and toxin positivity. Again, odds ratios usually less than 2. Again, most of these are most non-randomized retrospective cohort studies, and the grade of evidence is low because the studies are heterogeneous. There's imprecision and plausible role of confounders from the observational designs. What about vitamin and mineral deficiencies? Vitamin B12, gastric acid is important for cleaving vitamin B12 from protein to allow absorption. So theoretically, you can understand that the plausibility of acid suppression interfering with vitamin B12 absorption, but again, odds ratio is quite low, 1.65 for vitamin B12 deficiency. There is some studies that show association with higher doses for longer periods and improvement after discontinuation, but most of us don't feel strongly about monitoring for vitamin B12 deficiency in the setting of long-term PPI use. Iron has also been thought to have potential decreased absorption because gastric acid releases iron from food and oxidizes it to a more absorbable ferric form, but again, based on observational studies and very little data. Magnesium actually has an FDA warning that there may be a drug effect of PPIs on the magnesium transporter, but again, mostly based on case reports. And again, you can see this odds ratio is around the same at 1.43. It seems to be worse among PPI users and concurrent diuretic users, so keep that in mind, as low magnesium can certainly lead to cardiac issues. Osteoporosis and fractures, another potential PPI risk. The FDA warning in 2011 shows that the patients at highest risk for fractures received high doses of prescription PPIs and or used a PPI for 1 year or more. Again, the mechanism seems to be questionable. Is it impaired absorption of calcium? But this doesn't seem to quite fit with the pathophysiology. But there is some data that there is an association between PPI use and risk of fractures, which is time and dose dependent. Again, the meta-analyses showed moderately increased risk of hip fracture, not osteoporosis, with a relative risk of 1.26, but a recent randomized controlled trial does not show increased fracture risk, and confounding comorbidities and falling risks are thought to play a role in this divergent data. So people often quote this recent randomized controlled trial by Palmiotti and colleagues, 18,000 patients with coronary artery disease, peripheral vascular disease, assigned to pantoprazole, 40 milligrams daily or placebo, and they found a statistically significant increased risk of enteric infections in those allocated to PPI, but lower risk than observational studies, odds ratio of 1.33. And all other safety outcomes were not statistically significant. And you can see what they looked at: gastric atrophy, C. diff, other enteric infections, chronic kidney disease, dementia, pneumonia, fractures, COPD, and diabetes mellitus. And this study is often quoted because it's actually a randomized controlled trial looking at the effect of a PPI versus placebo. So in summary, for PPI adverse events, the majority of associations are based on observational studies. They're usually pretty weak associations. Confounding and bias can play certainly a role when the odds ratio is less than 3. So you can assume a possibility or a plausibility of a PPI adverse event, but mostly I would say that these medications are safe if clinically indicated. But my take-home points are that acid suppression is commonly used in cystic fibrosis patients, but the most common indication being gastroesophageal reflux disease and optimizing pancreatic enzyme replacement therapy. Acid suppression may have potential adverse effects, as I mentioned, And so it's very important to reevaluate the need for acid suppression, and it's important to find out how are they diagnosed with gastroesophageal reflux disease, or, and why are they using acid suppression for pancreatic enzyme replacement therapy, and are there alternatives? Because not every CF patient needs lifelong acid suppression, and we know that a lot of patients are prescribed PPIs. They're usually pretty cheap. They're overall considered safe medications, and many do not have the right indication for these medications and should be considered for a potential weaning protocol.
Good afternoon. My name is Jill Dorsey, and I'm a pediatric gastroenterologist in Jacksonville, Florida. I appreciate the opportunity to talk to you today about management of bloating and small intestinal bacterial overgrowth. I have nothing to disclose. As you know, cystic fibrosis is a multisystemic disease involving a vicious cycle of obstruction, infection, and inflammation. Typically, we think of this involving the lungs, but this vicious cycle can be found in the intestinal tract of individuals with CF as well. In the CF gut, there is impaired luminal flow due to a highly thickened mucus layer, epithelial inflammation, infection, and dysbiosis. The CFTR protein is functionally expressed at the apical membrane of enterocytes, where it mediates secretion of chloride and bicarbonate across the epithelial layer. This bicarbonate is required for normal expansion and solubility of the intestinal mucus. If CFTR is not functioning and there is a decrease in bicarbonate, then you will see an increase in viscosity and impairment in mucus propagation through the intestinal tract. This becomes an ideal environment for colonization of bacteria and alteration of the normal microbiome. You can see this nicely to your right in the slides from the CF mouse intestine, which show accumulation of thickened mucus and a large amount of bacteria. In the human gastrointestinal ecosystem, there are approximately 300 to 500 bacterial species or microbiota that make up a microbiome of nearly 2 million genes. The number of bacteria within the gut is approximately 10 times that of all of the cells in the human body. At birth, the gut is sterile, but by about 2.5 years of age, the microbiota reach adult composition. The overall number of bacteria in the small intestine is much less than what is found in the colon. So when there is a disruption of the normal intestinal environment that results in a significant increase in the number of bacteria in the small intestine that cause gastrointestinal symptoms, this is considered a disease state called small intestinal bacterial overgrowth, or SIBO. These bacteria are usually coliforms, which are typically found in the colon and include predominantly gram-negative aerobic and anaerobic species that ferment carbohydrates producing gas, which can lead to bloating. In the CF intestine, the thickened mucus acts as an anchor for the bacteria, which allows them to accumulate. It also impairs the normal bacterial defenses provided by the intestinal epithelial Paneth cells. With these changes, it is not surprising that approximately 30 to 40% of individuals with CF are thought to suffer from SIBO. In CF mouse model, SIBO has been seen within 4 days of birth. The timing of onset in individuals with CF is unclear. The clinical presentation of SIBO is nonspecific. Individuals can present with a variety of symptoms like diarrhea, abdominal pain, bloating, flatulence, weight loss, and nutrient malabsorption, especially vitamin B12, iron, and vitamin D. Please keep in mind that these same symptoms can be found in a variety of other conditions like infections, celiac disease, inflammatory bowel disease, and laxative abuse. So please make sure to consider these other possibilities in your differential diagnosis as well. The diagnosis of SIBO is difficult. The gold standard is to directly sample the bacteria from the small bowel. This is typically done endoscopically by aspirating fluid from the duodenum. You can see on your right that an endoscope has been introduced in the mouth down to the duodenum. Here, an aspiration catheter is then passed through the working channel of the endoscope, and the tip is positioned by the third or fourth portion of the duodenum to collect the fluid. However, in individuals with CF, the bacteria are likely to be predominantly in the mucus layer, which is poorly soluble and strongly adheres to the intestinal wall. So simply trying to aspirate the fluid will not obtain an adequate sample. It has been suggested that biopsies may be needed in this situation, so directly sampling the small bowel is obviously invasive. An alternative method to diagnose SIBO is the lactulose or glucose breath test. The premise of breath testing is that human cells are incapable of producing hydrogen and methane gases. So if these gases can be detected in breath samples, it must signify another source, such as the fermentation of carbohydrates by microbes in the gut. So after a patient ingests the lactulose or glucose, it is exposed to the bacteria and the sugar is rapidly fermented to produce hydrogen gas that gets absorbed into the bloodstream and then is exhaled through the lungs. It is then collected and measured. A group of microorganisms called methogens use hydrogen as a substrate for the production of methane. A rise in the concentration of hydrogen or hydrogen plus methane in breath samples makes the diagnosis of SIBO. Successful completion of breath tests for SIBO can be tedious. There are a number of factors that may influence the results of the breath test, as you can see here. For example, antibiotics may alter the microbiota composition. How quickly the intestines are moving will also influence how accessible the carbohydrate load is to the bacteria, so it is recommended to avoid promotility agents and laxatives for at least 1 week prior to the testing. We typically do not schedule children less than 4 years of age for breath testing because of compliance issues. The test itself is long. Typically, breath samples are obtained every 15 minutes for 2 to 4 hours, so patients are usually encouraged to bring something to do to pass the time. As you can already see, there are a number of details that influence the results of the breath test, and some may lead to false positives or negatives. For example, metabolism of lactulose may actually represent fermentation by colonic bacteria and not bacteria located in the small intestine. Also, it has been emphasized in the literature that individuals with CF are more likely to produce methane, perhaps because of frequent antibiotic use. So it is important that both hydrogen and methane are measured during testing. Delayed intestinal transit may also alter the results of the breath test. This is potentially problematic in individuals with CF since dysmotility is common. Since objective testing for SIBO in the CF population is potentially difficult, empiric treatment is an acceptable alternative. Antibiotics are the cornerstone of treatment. Typically, an antibiotic that targets gram-negative and anaerobic bacteria is preferred. 2 examples are metronidazole and rifaximin. Rifaximin is a non-absorbable antibiotic, which is attractive in the CF population given that they tend to receive multiple courses of antibiotics over their lifetime. However, it is expensive and sometimes difficult to obtain coverage through insurance. Amoxicillin clavulanate has been shown to stimulate duodenal contractions when given before a meal, which may be helpful in individuals with decreased intestinal motility. It is likely that a single course of antibiotics will not eradicate SIBO, so it is common practice to retreat with another course of antibiotics, although this practice is based on anecdotal evidence and expert opinion. One published non-CF study assessed the frequency of SIBO recurrence in 80 adults following a course of antibiotic therapy and found the recurrence rates of 12.6% at 3 months and up to 43.7% at 9 months. A single study evaluated the use of repeat antibiotics to treat SIBO and prevent recurrence in 51 patients with systemic sclerosis. In this study, the patients were given 7 days of norfloxacin followed by 7 days of metronidazole for 3 months. Both the presence of SIBO and SIBO resolution were assessed by glucose breath testing. The authors found that 52% of subjects exhibited eradication of SIBO and significant improvement of their intestinal symptoms after treatment. A possible alternative to antibiotics has been raised from a study with CF mice. Delisle et al. Found that the use of a PEG-based laxative was successful in decreasing bacterial overgrowth by 92% in CF mice. This was also observed in the clinical setting by Fridge et al., where the use of daily PEG or docusate sodium decreased the likelihood of a positive breath test in a small group of CF patients. Based upon the available literature, a suggested clinical algorithm for management of SIBO in individuals with CF has been proposed. It is very important to point out that prior to initiation of any treatment, you need to assess for the presence of red flags in the clinical history, like focal abdominal pain, persistent vomiting, vomiting that contains blood or bile, or blood in the stool. If any of these symptoms are present, then you need to involve your local gastroenterologist. If a gastroenterologist is not available, then please partner with the individual's primary care provider and consider emergency department evaluation, especially if the patient is ill-appearing. It is also equally important to reassess and consider other diagnoses if symptoms do not improve as expected after treatment. More recently, there has been a lot of interest in dysbiosis in individuals with cystic fibrosis. Recall that the thickened mucus of the CF gut can become colonized with bacteria that alters the normal microbiome. Frequent exposure to antibiotics was thought to be a risk factor for this. However, at least one study has shown that the changes found with antibiotic use resolve shortly after the antibiotic course is completed. Another small study found in all its subjects that the composition of the gut microbiota stabilized by the end of the experiment, and some of the bacterial communities partially recovered, but overall the microbiota was altered from its initial state. So the long-term effects of antibiotics is not clear, and more studies need to be done. Meeker et al. Used germ-free mice to assess whether CFTR dysfunction alone was sufficient to alter the microbiome. They performed fecal transplants with the same donor microbiota for both the germ-free CF mice and non-CF mice. They then analyzed the composition of the fecal and cecal microbiota 1 to 3 months after the transplant. The authors found that the alpha diversity was reduced in both the fecal and the cecal samples collected from the CF compared to the non-CF mice. The authors also noted that the CF cecal content was used as the donor sample for non-CF mice, and that the microbiome actually changed to that of a non-CF microbiota. Further evidence for this hypothesis is found in a longitudinal study from the Netherlands, which followed 20 CF infants as well as 45 healthy age and sex-matched controls. Differences in the microbiota between the CF infants and the healthy controls were already seen between 1 month and 4 to 6 months of age prior to any antibiotic use. Potentially pro-inflammatory bacteria, such as E. coli, were more abundant in the infants with cystic fibrosis. The authors found that the CF infants with cumulative antibiotic exposure had a decrease of bifidobacterium, which is thought to be important in intestinal health. Conditions like inflammatory bowel disease and type 2 diabetes have also been associated with a decrease in bifidobacterium. Hoffman et al. Found that younger CF children already demonstrated a higher abundance of gram-negative bacteria E. coli compared to children without CF. DeBiser et al. Demonstrated an increase in Ruminococcus navis in patients with CF, but not their unaffected siblings. The increased mucus within the CF gut tracts may preferentially select the R. navis strains since they are known mucin degraders. Differences in the degree of dysbiosis have also been shown among individuals with CF depending on the severity of their disease. Higher levels of E. coli and Eve biforme were found in homozygous F508del patients and in patients classified as having severe disease. Higher levels of F. presnitzi Bifidobacterium and E. limosum were found in patients considered to have milder disease. Hayden et al. Completed a prospective study collecting fecal samples from 207 infants with CF from the BONUS study and compared their fecal microbiota to that of age-matched healthy controls. The authors controlled for diet, low weight, and antibiotics. They found that those with low length had low relative fecal abundances of Bacteroidetes and high abundances of Proteobacteria. Furthermore, the authors found that dysbiosis was most pronounced among those with CF and low length. The authors raised the possibility that therapies to address the dysbiosis may improve early growth. As you can see, the presenting symptoms for intestinal dysbiosis are often nonspecific and are pretty similar to those found with SIBO. Patients may present with bloating, abdominal pain, diarrhea, and rarely with severe fulminant pancolitis with C. diff. To diagnose C. diff, stool is sent for culture or PCR with testing for toxin A and B by ELISA. Denaturating gel electrophoresis and high throughput sequencing of 16S rRNA is used mainly in the research setting to assess diversity and quantify the abundance of the fecal microbiome. However, these techniques are not ready for incorporation into clinical management because reference ranges have not been established and validated. Based upon the literature, individuals with CF are at risk for developing dysbiosis. So what do we have available for treatment? Well, what about probiotics? The NIH defines probiotics as live microorganisms that are intended to have health benefits when consumed or applied to the body. There is some evidence that probiotics may be helpful in other conditions like necrotizing enterocolitis, pediatric atopic dermatitis, inflammatory bowel disease, and antibiotic-associated diarrhea. So it would seem reasonable to theorize that probiotics may be helpful in CF as well. 2 systematic reviews looked at 6 randomized controlled trials and 3 non-randomized trials to try to answer this question. There was some evidence that probiotics help to decrease abdominal pain, intestinal inflammation, and pulmonary exacerbations in some of the studies that were reviewed. However, both systematic reviews concluded that there was insufficient evidence to recommend probiotics. It is noted that the dosing and specific strains of the probiotics varied between the reviewed studies. More recently, a Cochrane database systematic review was done, which evaluated 17 trials, including 12 randomized controlled trials. No difference between probiotics and placebo for height, weight, or BMI was found, and there was no change in abdominal symptoms. The authors concluded that there was a decrease in fecal calprotectin, but little or no difference in the rates of pulmonary exacerbations. As noted previously for the 2 systematic reviews, these authors also noted a wide variability of probiotic composition and dosages in the reviewed studies. Although we typically think of probiotics as a natural intervention, we as healthcare providers need to be cautious if we are intending to use them as treatment for a medical condition. In many countries, probiotics are not regulated as drugs, but as food supplements. Even in the United States, probiotics are only regulated if they are marketed to treat a specific disease or disorder. Also, it is possible that your patients are already taking a probiotic. The 2012 National Health Interview Survey showed that about 4 million US adults and 300,000 children had used probiotics or prebiotics in the previous 30 days. 57% of those were using them daily, and the remainder used them only during courses of antibiotics. Among adults, it is the 3rd most commonly used dietary supplement other than vitamins and minerals. A CF clinic in Vermont surveyed their patient population and found that 60% of their patients were already taking probiotics. It is also important to remember, since the majority of the probiotics are not regulated, that what is listed on the product label may not be what is found in the bottle. Newmaster et al. Looked at 44 herbal products from 12 different companies. 1/3 of these products contained contaminants and/or fillers that were not listed on the product label. Product substitution occurred in 30 out of 44 of the products tested, and only 2 out of the 12 companies had products without any substitutions or contamination. The authors report that some of the contaminants that were found had the potential for serious health risks to consumers. After reviewing the literature, the European Society for Gastroenterology, Hepatology, and Nutrition, or ESPGHAN, sought to raise awareness of the importance of quality control for probiotics. They expressed concern about the quality of the probiotic products due to factors like misidentification of strains, contamination of products, strains that were not viable, or the labeled number of colonies could not be verified. They advocated for a more stringent quality control process for probiotics. With the quality of probiotics in question, one would wonder if taking probiotics would be harmful. There is limited reporting in the CF literature of side effects from probiotics. One study reported mild flatulence in 3 patients, and 2 trials reported vomiting and diarrhea. There was one randomized controlled trial that was terminated prior to completion related to a severe allergic reaction of 1 patient. Obviously, more research needs to be done in the CF population. So with all of this information, I wanted to stress a few take-home messages. First, please remember that small intestinal bacterial overgrowth is fairly common in cystic fibrosis. There are limitations of testing for SIBO, so empiric treatment with antibiotics or PEG-based laxative is reasonable. Clinical symptoms of SIBO and dysbiosis are similar, and there is currently insufficient evidence to recommend routine use of probiotics in cystic fibrosis. I wanted to thank Dr. Makbul and Dr. Hatcham for the opportunity to speak today, as well as my Nemours CF team, and of course, Digest. Thank you.
Hello, my name is Sabina Saberwal, and I'm a gastroenterologist at the Cystic Fibrosis Center at Boston Children's Hospital. And I'm going to talk about the surgical treatment of GI conditions in CF today. I have no disclosures. The objectives of this talk are to understand the surgical management of the following CF GI conditions: meconium ileus, distal intestinal obstruction syndrome, and gastroesophageal reflux disease. Meconium ileus occurs in 20% of patients that are diagnosed with CF. It's most commonly associated with class 1 through 3 CFTR mutations. It's associated with defective bicarbonate secretion, which then results in acidic intestinal luminal environment. This results in thick dehydrated mucus and in increased levels of albumin, mineral content, and protein-bound carbohydrates. The combination of these above 2 things will lead to terminal ileal obstruction. MI is classified as simple and complex. Simple MI is obstruction of the terminal ileum and the proximal small bowel with this viscid meconium that we discussed, with an accumulation of meconium gas and fluid proximal to that site of obstruction. Complex MI involves distended segments of ileum, which lead to complications such as prenatal volvulus, ischemic necrosis, atresia, perforation, or peritonitis. Complex meconium ileus is classified as 50% of cases. In terms of a treatment timeline for meconium ileus, just to compare from now versus previously, in the 1960s, the mortality rates were up to 33% for meconium ileus. Today, early and late survival is well over 80% and even 90%. 1948, Hyatt and Wilson had described an intraoperative disimpaction of meconium ileus using saline solution. And in 1969, Noblet used gastrographin enema to manage simple meconium ileus. This minimized small and large intestinal resection for meconium ileus and really revolutionized the way it was treated. The clinical presentation of meconium ileus and meconium peritonitis can be seen on prenatal ultrasound in the form of hyperechoic bowel and peritoneal calcifications. Within hours of birth, Bilious emesis, abdominal distension, and delayed passage of meconium can be noted. And in complex MI, fever, abdominal tenderness, and shock. The differential to think about are meconium plug syndromes, atresias, volvulus, and Hirschsprung's disease. In terms of evaluating meconium ileus, the first thing is to stabilize the patient, and then really to understand whether this is more of a simple or a complex meconium ileus. If simple, we would do a diagnostic contrast enema as described, and we would use a gastrographin enema or an omnipaque or cystocontrae enema also described to see if you can resolve the meconium ileus. If you cannot resolve it using these methods, then surgical intervention is indicated for persistent MI. Also, if immediately identified as complex MI, surgical intervention is indicated. Surgical intervention for MI involves an enterotomy and decompression procedure, enterostomy with or without a tube with subsequent irrigation. This generally lasts about 7 to 14 days. An enterocutaneous fistula is involved, which spontaneously closes. The other two possible options for procedures are resection and enterostomy, and resection and anastomosis. The most common procedure is the Bishop-Koop procedure that's currently being used. This is in the figure on the right, letter B. Roux-en-Y construct distal limb is brought out as an end stoma with proximal bowel and an end-to-end anastomost. You can manage distal obstruction through the ileostomy, which is a benefit of this procedure. The Santulli and Blanc procedure, which is letter C in the figure on the right, is actually just the reverse of the Bishop-Koop. And because of the way it's been reversed, there's an inherent risk of dehydration via the proximal stoma to be mindful of. So the Bishop-Koop tends to be the most commonly used surgical technique. Primary resection and anastomosis is also described. It involves resection of obstructed segment of bowel, irrigation of pellets in the distal bowel, and ileocolonic anastomosis. The advantage is that it does not require a second procedure for intestinal continuity later. Disadvantages include complications such as anastomotic leaks, and also that it often involves resection of additional bowel at the time of anastomosis. Postoperative management of MI includes TPN, which is very common, but enteral feed should be initiated as soon as possible. With complex meconium ileus and poor gut perfusion, amino acid or protein hydrolysate rich in MCT oil formulas are recommended for enteral feeds, for example, Elecare. It's important to obtain a fecal elastase sample to confirm pancreatic insufficiency from rectal formed stool and not watery enterostomy stool, and to empirically start pancreatic enzyme replacement therapy, even while waiting to obtain a proper sample for the above. Postoperative complications from meconium ileus procedures include high output stoma losses, particularly in the form of sodium. This can lead to metabolic acidosis and poor weight gain. It's important to supplement sodium, either through TPN or enterally. Neonatal cholestasis, both from PN use as well as just underlying cholestasis, which patients at CF are higher risk for. Adhesions, anastomotic ulcers, and anastomotic strictures, and increased risk for constipation or dios later in life. Also, increased risk for SIBO later in life. Outcomes in CF meconium ileus patients have been looked at. There was a retrospective multicenter observational as well as case control Italian study that was done over a 6-year period. And it was done to understand the factors that were related to negative outcomes at 1 year of age following MI. In that study, it was found that the need for further surgery or subsequent intestinal resection, the presence of a stoma, or surgical complications did not favor an adverse outcome. Compared to age-matched controls of CF that had no meconium ileus, CF patients with meconium ileus had the same pulmonary function, nutritional status, and infection risk. Shifting gears to distal intestinal obstruction syndrome, which is really considered a meconium ileus equivalent later in life, the ESPGHAN working group had defined in 2010 complete versus incomplete DIOS. One being complete intestinal obstruction, evidenced by vomiting of bilious material and or air fluid levels in the small intestine on an abdominal radiograph, a fecal mass in the ileocecum, and abdominal pain and or distension. Complete DIOS is defined as 1, 2, and 3, and incomplete or impending DIOS is defined as 2 and 3 without 1. It's important to differentiate DIOS from constipation. Constipation is longer standing symptoms, less acute, with fecal material distributed throughout the colon on an abdominal X-ray. It's important to utilize abdominal X-rays to differentiate between constipation and DIOS. The pictures on the right are an example on an abdominal radiograph of distal intestinal obstruction syndrome with dilated loops of small bowel that can be seen on the X-ray above, and then below on a contrast study. In the center, you can see these small bubble-like appearance of inspissating meconium. Risk factors for DIOS include a severe CFTR genotype, pancreatic insufficiency, dehydration, poorly controlled fat malabsorption, history of meconium ileus and DIOS previously, post-organ transplant, as well as CF-related diabetes. Treatment for DIOS again involves classification as partial versus complete. For partial DIOS, there would be rectal disimpaction with a saline enema, lavage with polyethylene glycol, often with a nasogastric tube. If unsuccessful, a gastrographin enema can be performed. For complete DIOS, nasogastric decompression and IV fluids would be initiated for stabilization. A gastrographin enema would be given, and if successful, you then follow that with a PEG lavage. And for severe obstruction or peritonitis, this is an indication for surgery. The surgical procedures for DIOS are associated with significant morbidity and mortality and are often reserved for cases where the above aforementioned have been a failure. Ileocolonic lavage with manual disimpaction is the most common surgical procedure. The disimpaction is done using a sodium chloride solution mixed with mineral oil, which is often administered via NG tube concurrently with what's going on with the lavage. Colonic lavage via appendicostomy tube if the above fails. Ileal diversion plus or minus bowel resection if the above fails. And there has been a case report of a modified antegrade contrast enema procedure, similar to what we would do with cecostomies for refractory constipation. Postoperative care involves early extubation and pulmonary toilet. N-acetylcysteine historically was given via NG tube to solubilize remaining stool. Enteral feeds plus pancreatic enzyme replacement therapy are to be started as soon as possible. And if postoperative ileus, to start PN to optimize nutrition. Gastroesophageal reflux disease in CF certainly has an increased prevalence. Factors that have been described are altered gastric emptying, intra-abdominal factors such as increased prevalence of hiatal hernia, nocturnal enteral feeds, an anti-reflux barrier failure, which results in diminished peristalsis, intrathoracic factors related to CF itself, postural drainage and chest PT, beta-adrenergic agents which induce lower esophageal sphincter relaxation, and frequent coughing. Gastroesophageal reflux and pulmonary disease has also been well described. Airway acidification is associated with respiratory exacerbations in CF. The gastroesophageal refluxate reaches the esophagus more in CF patients, and they're more prone to pulmonary aspiration of this gastric content. Esophageal acid exposure related to cough in CF patients has been described. And increased bile acids in the sputum of CF patients are associated with higher inflammatory response. So this is non-acid reflux, which has also been seen in CF patients and can also cause inflammation, as noted on impedance probes. GERD treatment in CF involves lifestyle changes, so smaller, more frequent meals, and then acid blockers and promotility agents. Of note, with proton pump inhibitor use, there's increased risk for community-acquired pneumonia and viral gastroenteritis in children. Bone health and renal function issues exist, as well as hypomagnesemia. It affects airway microbiota, which can be associated with a decline in FEV1. Patients post-lung transplantation, particularly with CF, have an increased acidic gastroesophageal reflux as measured by pH testing. Indications for a Nissen funduplication are for patients with gastroesophageal reflux disease who only partially respond to acid suppressive therapy as an alternative to long-term medical management for chronic gastroesophageal reflux disease, and for patients who cannot protect their airway or who are at risk for aspiration of gastric contents. The procedure itself involves wrapping the fundus, or the top part of the stomach, around the backside of the esophagus and securing the wrap with sutures to anchor the lower esophagus below the diaphragm. Complications of funduplication include more immediate complications such as gas bloat, retching, and even dumping syndrome, and then esophageal strictures, wrap disruptions, and post-funduplication GERD, which are more chronic complications. Two major studies have looked at outcomes of funduplication in patients with CF. One, done by Bosch et al. In 2007, was a retrospective review of 25 CF patients who underwent a Nissen funduplication over a 6-year period. The symptoms leading to evaluation for GERD were preoperative symptoms such as recurrent vomiting, poor weight gain, heartburn or epigastric pain, and decline in pulmonary function. And preoperative testing involved an upper GI series, esophageal pH monitoring, gastric emptying scan, and an endoscopy with biopsy, which interestingly was only done in 3 of the patients. Complications of fundo that were noted were major complications such as intraoperative complications, perforation and peritonitis, paraesophageal hernia, strictures and wrap disruptions, and then minor complications, escalation or initiation of medical therapy, retching, emesis, heartburn, and epigastric pain. There was no statistically significant changes in nutrition or pulmonary function outcomes a year after fundo. Weight percentile, BMI, and BMI percentile were unchanged, and the mean slope of decline in FEV1 was minus 2.5% over the year before fundo and minus 2.1% over the year after, which was not statistically significant in this study. Interestingly, in those that had severe lung disease, defined as an FEV1 of less than 60%, the BMI percentile had improved and the FEV1 slope improved compared to those with mild lung disease. A second study in 2013, also retrospective, looked at patients over a long period of 20 years and a higher number of patients at 48 who underwent Nissen and had CF. In this case, they compared data 2 years before and 2 years after fundo, so also for a longer period of time. At 1 year after surgery in this study, the FEV1 significantly improved to 71%, but deteriorated to 67% by 2 years after Nissen. The difference in mean change in percent FEV1 in the 2 years before surgery compared to the mean change in the 2 years after surgery was also found to be significant. The mean improvement in weight in the 2 years after surgery was 2.26 kilos, and both receiving G-tube feeds for more than 6 months after surgery and having mild disease as defined by an FEV1 greater than 60 percentile were significant factors in improvement in weight at 2 years after surgery. What about funduplication in lung transplantation? GERD is common after lung transplantation, and it can contribute to mortality and development of bronchiolitis obliterans syndrome. Lung transplant recipients that have an abnormal esophageal pH study attain a lower peak allograft function and diminished 1-year FEV1 after transplantation. This was seen in a study of over 200 patients in 2011 that had undergone lung transplantation. A significant percentage of those patients had CF. Funduplication in lung transplant recipients with GERD is associated with a significant improvement in lung function. This has not been studied exclusively in CF, but is a known association in patients that have had fundo after lung transplantation. In conclusion, the use of contrast enemas, better surgical techniques, and early nutritional support has resulted in a prognosis for CF patients with MI comparable to CF patients without MI. With the early initiation of treatment with PEG lavage and/or gastrographin enema, acute severe distal intestinal obstruction syndrome can be mostly managed non-surgically. If uncontrolled gastroesophageal reflux disease is present and does not respond to medical management, early Nissen funduplication may be helpful in preserving lung function and improving pulmonary status in patients with CF. Thank you very much.